Good evening, and thank you so much, everyone, for joining Halton Region Public Health tonight as we learn about the recent updated alcohol guidance and the clinical implications in primary care. I'm Heather Burnett. If we haven't met before, I'm the Physician Engagement Specialist for Halton Region Public Health and your host for tonight. An extra warm welcome to those who are joining us from outside of Halton Region. And tonight we're going to be learning about the clinical implications of the new guidance on alcohol that replaces the previous low-risk alcohol drinking guidelines. Before we get started, I'd like us all to take a minute to watch and reflect on this important video.
Bonjour, Sego, Tanshe, greetings. Halton Region acknowledges the treaty lands of the Mississaugas of the Credit First Nation, as well as the traditional territory of the Haudenosaunee, Huron-Wendat, and Anishinaabeg on which we gather. In stewardship with Mother Earth and the enduring Indigenous presence connected to these lands, we acknowledge the Indigenous nations of the past, present, and future. In the spirit of allyship and mutual respect, we will take the path of truth and reconciliation to create change, awareness, and equity as we strive to elevate the collective consciousness of society. Miigwech, Nyawe, Marcy, thank you.
Here you'll see a quick overview of our time together tonight. Our keynote speakers tonight are Dr. Peter Butt, who's the co-chair for the 2023 Canadian Guidance on Alcohol and Health, and Dr. Hamida Megani, Halton's Medical Officer of Health. Later this week, I'll be emailing you out an evaluation, in addition to sending you the slide deck and a link to the webinar recording. In order to receive your certificate of completion, for those of you looking for Main Pro Plus credits, please complete and return the evaluation to us, and then we'll email you the certificate within a few weeks. Because of the March break, we'll probably be sending out the certificates the beginning of April. If you're new to our sessions tonight, I'll just go over some housekeeping quickly. During this session, everyone is muted, and if you have any technical difficulties, please send an email to javier.rincon@halton.ca, and I will put the address in the chat box shortly. During our webinar, we do have the chat function that's available, but if you have questions, please don't ask them in the chat box. You can put them in the Q&A box instead. Once we get to the Q&A portion of the agenda, you can write your questions in the box. You can upvote a question by clicking the thumbs up icon, and that way the question will get moved up further to the top of the line. You can also comment on or answer a question. Tonight's webinar is the first in a three-part webinar series for this year. Here you'll see the overall learning objective, which essentially says we hope these updates will help you prevent, diagnose, and manage key public health issues impacting your patients. And for tonight's session, we're focusing on alcohol and how its consumption contributes to health risks for various diseases. We also want to make sure that we leave you with some ideas on how to easily incorporate conversations about alcohol consumption into various patient interactions you're already having. Any potential bias throughout the presentation by using data, resources, and recommendations from current scientific literature and information. So without further ado, on this International Women's Day, I'd like to introduce our first speaker, Dr. Hamida Megani. Dr. Megani is the Commissioner and Medical Officer of Health for Halton Region. She's a public health and preventative medicine physician, as well as a fellow with the Royal College of Physicians and Surgeons. Dr. Megani has a Master's of Public Health and Family and Reproductive Health and a Master's in Management Health Leadership. We're so glad she's able to join us tonight. Hamida.
Thanks so much, Heather, and happy Women's Day to all. So we'll just start off with my declarations or disclosures to financial support. I am a paid employee of Halton Region, and the region receives funding from the province of Ontario for mandatory public health programs and services, which includes my salary. Next up. You have no doubt heard about the updated guidance on alcohol in the news. We're so fortunate to have one of the co-leads of this guidance as our keynote speaker today. So I won't go into too many details about the actual guidance, but we'll take a quick look at what the changes are before looking at alcohol consumption and harm-related statistics for Halton and Ontario. On January 17th of this year, the Canadian Centre on Substance Use and Addiction, with the support of Health Canada, released Canada's Guidance on Alcohol and Health. This new guidance replaces the 2011 Canada's low-risk alcohol drinking guidelines and is based on the most up-to-date alcohol research. There is now overwhelming evidence showing that even small amounts of alcohol can have a health impact, and that it does not matter what kind of alcohol it is: wine, beer, spirits, or cider. The guidance focuses on the fact that drinking alcohol, even a small amount, is damaging to everyone, regardless of age, sex, gender, ethnicity, and tolerance for alcohol, and recommends that people consider reducing their alcohol consumption. More simply put, the overarching message is drinking less is better. But of course, there is still no known safe amount of alcohol use when pregnant or trying to get pregnant. When breastfeeding, not drinking alcohol is safest. The new guidance outlines a continuum of risk associated with drinking, rather than outlining a specific number limit for weekly and daily amounts of alcohol use. The risk of harm is low for people who consume 2 standard drinks or fewer per week, moderate for those who consume between 3 and 6 standard drinks per week, and increasingly high for those who consume 7 or more standard drinks per week. Even though this represents a significant reduction in the number of drinks per week considered as low-risk alcohol consumption compared to the 2011 guidelines, the new guidance is less prescriptive than the 2011 guidelines and supports that any reduction in alcohol consumption is beneficial. Corroborating the findings from the Canadian Centre on Substance Use and Addiction, the World Health Organization has also declared that the harms associated with drinking alcohol are well documented, and that when it comes to alcohol consumption, there is no safe amount that does not affect health. Alcohol is one of the top 5 risk factors for death and disease in the world. It is a causal factor in over 200 disease and injury conditions, and it's a leading preventable cause of death, disability, and social problems, including 7 types of cancers, cardiovascular disease, liver disease, FASD, unintentional injuries, and violence. The most recent available data shows that the use of alcohol causes nearly 7,000 cases of cancer deaths per year in Canada, with most cases being breast or colon cancer, followed by cancers of the rectum, mouth and throat, liver, esophagus, and larynx. I should also comment on the commonly held belief that drinking in moderation offered protection against coronary artery disease. Research reviewed from the past 10 years and the new guidance advises that drinking a little alcohol neither decreases nor increases the risk of ischemic heart disease. Alcohol use is now considered a risk factor for most other types of cardiovascular disease, including hypertension, heart failure, high blood pressure, atrial fibrillation, and hemorrhagic stroke. Another health risk to consider is that you may have some patients who are binge drinking without even realizing it. Here, you can see that one drink is equivalent to one 12-ounce bottle of beer, one 5-ounce glass of wine, and 1.5 ounces of spirits. You've likely seen people pour glasses of wine that far exceed 5 ounces, and many drinks are sold and served at much larger portions than this. Binge drinking is defined as consuming 5 standard drinks or more for men or 4 standard drinks or more for women in one setting, and is a common yet dangerous pattern of consumption that leads to a range of acute health and social problems, such as alcohol poisoning, suicide, impaired driving, drownings, falls, physical and sexual violence, and may lead to the development of an alcohol use disorder. If you think about a standard bottle of wine, which is 750 mils, that means it holds a little over 5 glasses of wine. If someone starts drinking a glass or 2 while they're cooking dinner, and then drinks a glass or 2 with their dinner, and then finishes the bottle off because you don't want to waste it, You could easily have patients that are binge drinking without thinking that they fit the stereotype of a binge drinker. They may also not fit an image that you have of a binge drinker, which is why it's so important to incorporate alcohol use conversations into our regular patient interactions. Now let's take a look at the burden of alcohol use provincially and what we know locally. Alcohol use has a substantial impact on our healthcare system. It is estimated that the total direct healthcare costs and indirect costs of alcohol use in Ontario are $4.5 billion per year. In February 2023, Public Health Ontario released a report that summarized the estimated burden of health conditions attributable to smoking and alcohol. The table on the slide highlights the estimated number of deaths, hospitalizations, and emergency department visits each year in the province attributable to alcohol, including conditions such as cancer, cardiovascular diseases, and injuries. They estimate that these alcohol attributable outcomes made up 4.3% of deaths, 2.1% of hospitalizations, and 3.7% of emergency department visits from all causes in people aged 15 and older in Ontario. Remember, alcohol-related harms are preventable. I thought it would be helpful to compare the burden of health conditions attributable to alcohol in Halton to the burden of COVID-19. Shockingly, they are fairly similar. In the roughly 3-year period from March 1st, 2020 to February 22nd, 2023, there were 1,765 hospitalizations and 412 deaths due to COVID-19 among Halton residents, compared to an estimated 2,184 hospitalizations and 375 deaths in a 3-year period related to alcohol use. In addition, the Public Health Ontario report estimates that 5,546 emergency department visits are attributable to alcohol in people aged 15 and over in Halton each year. That's a lot of hospital visits that could be reduced. Historically, alcohol consumption has been one of the few health indicators where Halton rates have been less favorable than the provincial average. However, more recent data from the 2019-2020 Canadian Community Health Survey suggests that the gap is closing. A 2021 survey found that the same percentage of Halton residents reported that they consume more alcohol since the beginning of the pandemic as the percentage who reported decreasing their alcohol consumption during the pandemic. A Canada-wide survey conducted in January 2021 by Statistics Canada had similar findings. Reasons reported for those who increased consumption during the pandemic included such things as having a lack of a regular schedule, boredom, stress, and loneliness. Those who decreased consumption cited reasons of there being a lack of social gatherings, wanting to stay healthy in case of testing positive for COVID, a lack of alcohol availability, and because of caring for loved ones. In 2019-2020, 31% of Halton adults aged 19 and over reported consuming more than 2 standard alcoholic beverages in the past week, in excess of the new guidelines. The same survey found that in 2019-2020, 14% of Halton residents aged 12 and over reported binge drinking in the last year. Research suggests that there are subsets within the population who are more likely to increase their alcohol consumption during the pandemic, including younger individuals, those with mental health concerns or experiencing social isolation, and parents of young children. Data from the CCHS capture a unique period of time that spans the year before and the first year of the COVID-19 pandemic. Restrictions on social gatherings and public places where alcohol is typically consumed, such as bars and restaurants, may have influenced alcohol use behavior during this time. As well, significant changes in provincial alcohol policy have increased alcohol availability in recent years. Next, let's take a look at alcohol sales information, which gives us another set of data on alcohol consumption patterns. Statistics Canada reported that total alcohol sales increased at the start of the pandemic in 2020-2021. An equivalent of 9.7 standard alcoholic beverages a week per Canadian of legal drinking age was sold in 2020 and 2021. which was an increase of 2.1% from the previous year. Sales increased 4.2% with 2.1% inflation for a total of $25.5 billion. This was the largest sales increase in over a decade. Most of the liquor authorities attributed this growth to the pandemic and its impact on purchasing habits. As well, policy changes in Ontario made it easier for Ontarians to access alcohol. During the pandemic, the province of Ontario added temporary regulations to increase alcohol access, including designating alcohol retail as an essential service and zoning regulations to enlarge outdoor space permitted for alcohol consumption. In addition, more long-staying policy changes made in 2019 and throughout the pandemic may have further increased alcohol sales. These include expanding the number of retail locations allowed to sell alcohol, allowing alcohol to be purchased with takeout food orders, reducing the minimum price of spirits, expanding hours of alcohol sales, and permitting third-party delivery of alcohol to a residence from restaurants, example through Uber Eats, the LCBO, the beer store, and other manufacturers. These policies remain in place today and are worrisome as we know that more access to alcohol leads to higher consumption rates. The most recent data reported by StatsCan from 2021-2022 regarding alcohol sales now indicate that the upward trend has not continued, seen as a slight decline to 9.5 standard alcoholic beverages per week per Canadian. While this is the first decline since 2013, albeit a small decline, it will be important to see whether there will be any changes in the future given the publicity of the new guidance and rising cost of living. This slight decline may also be due to some reports that younger generations are drinking less than predecessor generations. Studies cite monetary issues, legalization of marijuana and its use as a cheaper substance alternative, negative studies linking alcohol consumption to health issues, and avoidance of hangovers as reasons that Gen Z and millennials are consuming less alcohol. Despite the decrease in volume sold, alcohol sales continue to rise. Overall, liquor authorities and other retail outlets sold $26.1 billion worth of alcoholic beverages in 2021-2022 in Canada, and $9.8 billion worth in Ontario, which was an increase from a year earlier. This increase in sales was driven by inflation, which rose 2.8% for alcoholic beverages. With so many sources of data, the story on how much alcohol Canadians are consuming is not straightforward. Therefore, it is imperative that we continue to monitor alcohol consumption and related harms in order to understand long-term trends. And now I'm very excited to introduce to you our keynote speaker, Dr. Peter Butt. Through the wonders of webinars, we're able to have experts from across Canada join us, and we're so grateful that Peter could join us tonight. Dr. Peter Butt is a certificate and fellow with the College of Family Physicians of Canada with special competency in addiction medicine. He's a clinical associate professor in the Department of Family Medicine at the University of Saskatchewan and served as a consultant in addiction medicine in Saskatchewan Health Authority. His research has included guideline development and knowledge translation, and he has extensive expertise on our subject matter tonight through his work chairing the original development of Canada's low-risk drinking guidelines in 2011, co-chairing the Canadian guidelines on alcohol use disorder among older adults in 2019, and recently having co-chaired the 2023 Canadian guidance on alcohol and health with the Canadian Centre on Substance Use and Addiction. I can think of no better speaker for us tonight. Peter, over to you.
Well, thank you so very, very much for that very kind introduction. And frankly, you've got the core of what we were trying to do with the guidance down so very well that very happy to see that. It's fabulous. Could I have the next slide, please? We'll move along in terms of some of the initial ones. But in terms of the disclosures of affiliations and interests, everyone participating in this project underwent Guidelines International Network processes for disclosure and mitigation. There were 23 experts from coast to coast, including Public Health Ontario's Aaron Holben, wonderful contributor, and in fact, 16 different organizations. Next slide. So personally, I really have nothing to disclose with regards to conflicts. I'm contracted as a clinical associate professor here at the College of Medicine at the University of Saskatchewan, as well as contracted in terms of research and knowledge mobilization with CCSA. The project, as noted, was funded by Health Canada under a grant and managed by CCSA. Next slide. The objectives we've already covered, so let's move right on to the slides with more substance. And this has been covered off already with regards to the previous guidelines released in 2011, the National Low-Risk Alcohol Drinking Guidelines. But since that time, it was becoming increasingly apparent that they were problematic. There were more developments with higher quality evidence on alcohol-related mortality and morbidity. There was more interest and also more research with regards to alcohol and social harms. And we also were monitoring what was happening internationally. So the UK came out with their guidelines, updated guidelines in 2014, followed by France and Australia. Australia released theirs in 2021, 2022. And all of them were less. Now, the thing to keep in mind is that there is not an international standard drink. Canada has 13.45 grams in a standard drink. Australia and France use a standard drink definition of 10 grams, and the UK uses 8 grams. So we have very different numbers when you look at what people have done internationally, but when you convert them to Canadian standard drinks, actually they come out to about 8 from the UK of our Canadian standard drinks per week, and 7 from France and Australia, compared to what we ended up in the higher end of the moderate risk zone of 6. Next slide. So we knew that it was time to update the guidelines, and we're quite pleased that Health Canada agreed and supported this project. However, we only had 2 years. Australia had 5. Next slide. We knew, however, that we would be using mathematical modeling and that we would be hopefully able to draw on the good work that the Australians did. The questions, of course, that we needed to address was, what are the long-term risks and benefits of beverage alcohol, the short-term risks and benefits, and what are the risks for women who are pregnant or breastfeeding? A significant change that has occurred from the 2011 guidelines was shifting the control group from current abstainers to lifetime abstainers. Current abstainers include sick quitters, people who are no longer able to drink because of their health or the medication that they're on. So it's a more problematic and more unhealthy cohort than lifetime abstainers. But that would make a difference in terms of the impact of alcohol on health. And that's really what we wanted to see, was what was the impact in terms of years of life lost when people are drinking increasing doses or amounts of alcohol compared to people who don't drink at all. So it was a whole health approach. Next slide. In order to do this, however, we needed to get the systematic reviews that would give us the best evidence possible. There are over 200 different ICD codes related to alcohol-associated conditions, and we wanted the best evidence that we could get. Fortunately, the work that the Australians did in their evidence review between 2000 and 2017 was very good. We used AGREE-2 and AMSTAR-2, as well as GRADE in terms of our evaluation. From 2017 to 2021, there was another almost 6,000 systematic reviews that were retrieved. We narrowed it down to 239 for full text eligibility, and actually ended up with 16 that met the criteria, because you can appreciate, particularly in this audience, that you want to tease out some of the confounding variables, such as cigarette smoking, looking for studies that are going to correct for self-reporting, and so on. Next slide. So the baton was turned over to Kevin Shield, a World Health Organization affiliated epidemiologist who works at CAMH. And we asked him to produce the risk curves, and we looked specifically for two different cut points or thresholds. The first one was for the risk level of 1 in 1,000. Could you click, please? Thank you very much. Now, as you know, in this audience, 1 in a million is acceptable risk for involuntary exposure in terms of safe water, air pollution, and so on. 1 in 1,000 is the risk level that's generally acceptable for voluntary activity. And in this case, it's about the level that we see with death from drowning. So we wanted that cut point. The other threshold that we wanted was 1 in 100. 1 in 100 is what's been used historically to define low risk for alcohol for social, economic, and cultural reasons. It's tenfold more than other risks that people voluntarily take. And it actually correlates fairly closely to the risk of dying from a motor vehicle crash. Now, it's easy to argue that driving in one's car is perhaps more essential than drinking alcohol, but we thought that it was important to be able to compare where we landed in terms of a whole health approach with these two thresholds. We also wanted to look at years of life lost, turned out to be 17.5, and also by sex in terms of males and females. And what we found at this next level is that at 1 in 1,000, that equated to 2 standard drinks per week. At 1 in 100, it came out at 6 standard drinks per week. And when we looked at males and females at this lower level, it was the same. The risk was not increased for women compared to men, despite their physiological differences with regards to decreased production of alcohol dehydrogenase and decreased lean body mass. However, with the sex and gender approach, it's important to emphasize that once you get into that 7+ range, the risks for women increase much at a steeper curve than for males. However, for males, there's a larger number that drink more and come to harm amongst that cohort. So we knew that telling everyone that they should only drink 2 standard drinks per week was a non-starter. You can't begin a conversation with that kind of an approach. And indeed, that's what Canadians were telling us. Next slide, please. Canadians wanted more information with regards to alcohol and mental health, alcohol in women. Per occasion drinking was topical, as was alcohol and violence. So because this information wasn't something that we could obtain through mathematical modeling, we had to contract evidence reviews. In focus groups, we also found the values and preferences of Canadians, and they wanted us to focus on the facts rather than strict rules or patronizing messages. They did not want finger wagging. They wanted to be informed about the existence of the guidelines and why they exist. Why do we need these? They wanted the messages kept short, simple, and clear. And they wanted us to meet people where they were at by providing them with actionable guidelines on alcohol. So telling somebody who's currently drinking well above 7 standard drinks per week that they need to drink 2 is a non-starter when we take these preferences into consideration. And this is why we developed the risk zone approach. Next slide. So what were the recommendations? And it's very, very simple. It's not the fact that, as reported in the media, that no one should be drinking more than 2 standard drinks per week. That's not where we started. Next slide. And we also, because we weren't landing on specific numbers, changed the terminology in terms of low-risk alcohol drinking guidelines to Canada's guidance on alcohol and health. Because what we want to do in this exercise is present people with the information, with the evidence, with the facts, prompt them to reflect on their alcohol consumption and consider to reduce it. in the context of their own individual health situation, as well as their risk tolerance. Next slide. So the first recommendation is very simple. To reduce the risk of harm from alcohol, it is recommended for people living in Canada to consider reducing their alcohol use. That's it, folks. It's that simple. To consider reducing their alcohol use. And arguably, because of the nature of the curve, people dropping from 16 to 14 standard drinks per week are going to experience improved health benefits that are much greater than those going from, let's say, 6 to 4 standard drinks per week. So this is something that's applicable to everyone. Next slide. With the risk zones, what we found is that in the literature, there's no safe level of consumption. As you increase consumption, risk increases. That's an important message. It doesn't mean that everyone's going to come to harm. And indeed, you know that when 1 in 1,000 is the threshold, that means one person in 1,000 is going to experience an alcohol-related demise, leading to 17.5 years of life lost. It's not something that's divided up amongst everyone. 1 to 2 standard drinks per week is fairly negligible in terms of the risk. And that's where the 1 in 1,000 threshold was. When you go from 3 to 6 standard drinks per week, you're getting into what we call the moderate risk zone, where you're beginning to develop increasing risk with regards to different types of cancer. And that would take us up to the 1 in 100 threshold. And above that, we felt that was increasingly high with demonstrable harm. Next slide. The communication of standard drinks is essential in terms of developing alcohol literacy. It's not easy in terms of people understanding how many standard drinks there are at the point of pour. That approximately 5 standard drinks in a bottle of wine is close at 12% alcohol content, but at 14%, it's going to be even more standard drinks. Similarly with beer, there are craft beer breweries that are coming out with lower content alcohol, as well as larger breweries. And without standard drink labeling, which you would think would be a benefit to the industry, it's hard for people to know how many of those they can have, as opposed to, let's say, a tall boy that might have 1.5 standard drinks. This is something that needs to be communicated at the point of pour. Next slide. With regards to per occasion drinking, what the evidence shows is that consuming more than 2 drinks in one occasion is associated with an increased risk of harms to self and others, including injuries and violence. And there's certainly a sex bias here. Alcohol and testosterone does not go well together. And what we see is a lot more of the accidents and injuries and violence are found amongst males. Next slide. With regards to reproductive health, again, no significant change from 2011, which is perhaps why it didn't get the attention it deserved in the media, because people, I think, should be reminded that alcohol is teratogenic as well as carcinogenic. So when pregnant or trying to get pregnant, there's no known safe amount of alcohol. And when breastfeeding, it's best not to drink. Next slide. So those were the primary recommendations. With regards to that sex and gender lens, as I commented on, above the upper limit of the moderate risk zone, health risks increase more steeply for women than for men. And with regards to males, far more injuries and violence. And this includes general violence, it includes intimate partner violence, and it includes sexual violence. These are more likely to happen when men are acutely intoxicated or have been drinking heavily. And the nuance around the messaging with regards to sex and gender is going to be important, just as it's going to be important with regards to non-binary populations who identify very strongly with gender, but their physiology is imposed by their sex. So this, again, is something that needs to be considered in the knowledge mobilization. We're really looking at a cultural shift here over a period of time with regards to the knowledge mobilization and our relationship with beverage alcohol. Next slide. So fundamentally, we felt that it was imperative that we respected the principle that people had the right to know. What they did with that information was up to them, but they had a right to know. And the overarching message is that less is better. Less consumption means less risk of harm, specifically with carcinomas, with risk factors for cardiovascular disease, as well as injuries, crashes, and violence. So this is what we're endeavoring to present to the Canadian public. And of course, we need healthcare professionals as part of that knowledge mobilization. Next slide. In order to help with it as well, we need to think about cost-effective public policies. And this is why we called for standard drink labeling to inform consumers at the point of pour how much they're drinking if they want to count their drinks and manage their alcohol intake. Health warning labels, you would think ethically, morally would be appropriate, as well as legally, because the industry has the responsibility to inform people of potential risks by using their product. We have health warnings with the plastic wrapping from IKEA, but strangely enough, with beverage alcohol, which is a class 1 carcinogen, which is a teratogen, there is no health warning, none whatsoever in many jurisdictions. Although 40 countries in the world do have some type of mandatory alcohol labeling. In some of those jurisdictions, they may provide guidance on alcohol and health labeling or the low-risk drinking guidelines. And indeed, they also may provide nutritional labeling. This actually would be a benefit to the industry wanting to promote lower alcohol content beverages that are also lower in calories. Next slide. So many of you, like us, were probably startled by the level of media attention that happened with the release on January the 17th. Next slide. And it was international. There have been over 2,500 articles and interviews generated with a potential reach of almost 6 billion people on the planet. This has gone international in terms of Time, The Guardian, the New York Times, and so on. Unfortunately, a lot of people in the media focused on the 2 standard drinks per week. And also, unfortunately, that seemed to be the focus of some of the negative commentary from healthcare providers who perhaps should have read the document a little bit closer, because that's not where we landed. It's very much a risk zone approach to help people situate their drinking and reduce. Next slide. So what we need further, of course, is dissemination into very different communities with appropriate tools. We need to provide those tools with training to healthcare professionals to help with knowledge mobilization. We want to work collaboratively. This would be through CCSA with Public Health Ontario or other healthcare organizations like the Canadian Cancer Society and so on, again, to work together to deliver this information to their constituents, and also set up exchanges and expert advice to help with all of this process. Next slide. So part of it with regards to healthcare providers is helping people to individualize their risk. We've gone through the population health information, but now we need to help people to really situate their personal risk with regards to alcohol, coming from their past medical history or their family history. Next slide. So tables such as this might be helpful. This is alcohol consumption by grams per day. And you see different conditions, a cluster of heart diseases, as well as cancers and cirrhosis of the liver. So if it's 13.45 grams of alcohol per day that a person is drinking, let's say 1 standard drink per day, that would be between 10 and 15 grams at the top there. And if you draw a line down vertically, you can see increased risk in terms of hypertension. We use 10% confidence intervals. So with regards to ischemic heart disease and ischemic stroke, they really don't get into that level where we felt a protective effect for those conditions was statistically demonstrated. So this is an example of the disappearing J curve. Nevertheless, we can't direct where the alcohol goes when we drink it. We can't direct what part of an organ it's going to affect when we drink it. It's a whole body impact, and we need to think about whole health impacts with regards to the amount that's consumed. So with regards to subarachnoid hemorrhages, atrial fibrillation, flutter, and hypertension, the net effect on the heart is not protective. What we see here in this slide as well is of the liver. And you even at that one standard drink per day, an increase in the risk of breast cancer and colon cancer. We recognized, as does the World Health Organization, 7 different cancers: oropharyngeal, laryngeal, esophageal, colon, rectum, breast, and liver. The World Health Organization is also looking at stomach and pancreas, but we didn't feel that we had sufficient evidence to really land on that ourselves at this point. With regards to the next slide, you see the impact, again, set up the same way for males, 13.45 grams per day. You see a slightly different profile in terms of increased risk for hypertension, atrial fibrillation and flutter, subarachnoid hemorrhage in males compared to females, somewhat of a not statistically significant protective effect. Relative to females, decreased risk of cirrhosis, but it's still there, not to be ignored. And similarly, particularly with liver cancer and oropharyngeal cancer, and some of the other cancers as well, of course, excluding breast, the increased risk is quite significant. Next slide. With regards to the criteria for cancer causation, as many of you know in the audience, it requires not only the epidemiological data in human populations to establish the association, but also animal models to reproduce the mechanism and demonstrable cellular impact with regards to the cellular impact of alcohol as a carcinogen. All of these criteria need to be met in order for us to be able to say that, yes, this is an alcohol attributable cancer. In this slide, again from the World Health Organization, you see the percentages of these cancers that are attributable to alcohol, much higher in the more proximal GI tract, decrease as you go more distally, and then there's breast. But as you know, the oral cavity, the oropharyngeal and esophageal cancers have a much lower incidence than that of colorectal and breast. So the impact is reversed than this slide indicates with regards to the number of people that would end up with a causally attributable cancer. Next slide. It might be a surprise to some of our cardiology colleagues, but the World Heart Federation came out with a policy statement in 2021 with regards to the impact of alcohol consumption on cardiovascular health. And they were quite clear that alcohol is not good for the heart. There's been a major reversal in the perception of alcohol in relation to cardiovascular health and disease. And overall, the risks due to alcohol consumption increase for most major cardiovascular diseases, including hypertensive heart disease, cardiomyopathy, atrial fibrillation and flutter, and stroke. They were obviously not impressed by the disappearing J curve and the not statistically significant impact in terms of a coronary artery disease. Next slide. So there are a number of very practical harm reduction strategies that we need to present to the public. We need to encourage them to keep track of how many drinks they are having per week. Again, they need to be able to count and manage at the point of pour. So this is where standard drink labeling would be most helpful. It would be best to decide on a weekly drinking target and to stick to that. If they can't stick to it, then that leads to another level of discussion with regards to what is their level of control over their drinking. It's important to eat before drinking and whilst drinking to slow the absorption of alcohol, to decrease the acute harms, to choose drinks with a lower percentage of alcohol or to dilute them, to drink slowly in small sips, to always have water, to alternate between alcohol and non-alcoholic beverages, and to explore alcohol-free products. This last one is something that the industry or certain sectors of the industry have already pivoted towards. There are more and more hospitality locations, restaurants, and indeed bars that are providing mocktails or alcohol-free beverages. There are more craft breweries experimenting with low and no alcohol beer, and increasingly even the multinationals are coming out with zero alcohol content. So there's more for consumers to explore. Next slide. We also need to be thinking about how we approach screening and brief intervention. This has been directed historically towards screening for an alcohol use disorder. However, with a whole health approach to alcohol, it gives us an opportunity to have discussions with regards to the potential impact of alcohol on one's health for many different conditions, anything related to the heart that people are coming in to be seen for in terms of hypertension and so on, anyone that needs a mammogram or is in a discussion with getting fecal occult blood testing to screen for colon cancer. You know, these are ideal opportunities to have a discussion with regards to the possible role of alcohol, because it's a number one preventable approach to addressing some of these cancers. In addition to the screening and brief intervention, however, we need to help people in primary care to provide the necessary anti-craving pharmacotherapy if a person should actually have an alcohol use disorder. In addition to referring to community resources, we want to encourage primary healthcare providers to follow up, to reassess, and provide the ongoing conversation all the way through to recovery support. So again, in order to talk about alcohol, we know from focus groups and other studies that people need to feel comfortable with managing alcohol use disorder, that this is often an impediment for screening with regards to alcohol use. Next slide. So in terms of the clinical implementation, we need the public knowledge mobilization. Healthcare providers are part of that public. We're impacted by what's in the media as well. We want to help professionals to develop skills to individualize risk. We need a revision of screening and brief intervention, and we need to increase knowledge and comfort with regards to treating alcohol use disorder. So some of this is much broader than simply providing the guidance on alcohol and health. But in order to do that, we need feedback from clinicians. What is it that they need or want as tools in order to engage in this? Next slide. The overall message, however, is quite simple. Less is better in terms of this continuum of risk. We want to prompt reflection and guide people down. Generally speaking, when it comes to advice, we want people to reduce with a potential goal of 6 standard drinks per week or less. If people are at risk of an alcohol attributable condition, they might want to consider 2 standard drinks per week or less. And indeed, if they have the presence of an alcohol attributable condition, they should consider abstinence. So that's a rational, triaged approach for these conversations that doesn't have to get into the sort of arcane discussion of what exactly is the risk, but rather engage people in that conversation around what is your relationship like with alcohol, what's your risk tolerance, and what are your health concerns in order to contextualize this. So with that, next slide, I think, next slide. Right, I think we can go to questions.
Perfect. Thank you so much for that, Dr. Butt. That was really, really interesting. We do have a couple questions that have come in, so I'm just going to read them out. So the first one is there any data on whether there is a difference in risk depending on what stage of life a person has higher alcohol use in. For example, some physicians hear patients say, well, I drank more in my 20s, but not so much now. Does it make a difference in that those different age and stages?
Well, certainly, couple of points with regards to that. The greater risks when people are younger tends to come from the acute harms, from acute intoxication. And then as alcohol use accumulates over time, they're going to accumulate more risk of harm. The good news is that if they decrease, they're going to be decreasing their risk. So over a period of time, physiologically, they'll settle. The liver will recover and they'll improve as long as they haven't gone too far and they're more terminal. In terms of older adults, we do know that there is a physiological difference. So people over the age of 60 or 65 have decreased lean body mass. There are other changes in terms of their metabolism of alcohol, and they'll drink for somebody who's a younger adult, they'll have a 30% increase in blood alcohol concentration. Now, if you add in the use of different medications, if you add in increasing vulnerability and frailty, as people age, the advice is to cut the guidance in half. So for an older adult, rather than aiming for 6 standard drinks a week, I would perhaps suggest, let's aim for 3 to begin with, and then continuing the taper from there, depending upon what their health conditions are. If there's an alcohol attributable one and they're already at high risk, I would have a conversation around considering 0. Because this isn't an attack on socializing, which unfortunately is sort of the emotional response that gets provoked. We can continue to socialize with low alcohol content beverages, with no alcohol content beverages. We need to address the stigma, which is reversed from drug use, where drug use is stigmatized if one uses. When it comes to alcohol, one's stigmatized if one does not drink. We need to engage in this cultural shift so that people are comfortable. It's okay not to drink. People shouldn't be made to feel comfortable if they choose not to drink, and that there are lots of options.
Great, thank you. The next question is in terms of, this is kind of moving into the next stage of that knowledge translation piece, is there work happening to include alcohol consumption in risk calculations, such as combining alcohol consumption with comorbidities? You talked about that just a little bit now, with family history of cancers, medication, lowering the risk guidelines for people that are older. Is there going to be some kind of like a clear guideline where, I know you had the charts, but is there going to be like, if you have a family history of this or this, then maybe you should be cutting it down to this many drinks?
Yeah, and that's what I was trying to present with the triaged approach. I didn't have a slide in the deck with regards to that. But when you think about it, again, this is population health data. So with regards to people in the general population, I think without any specific alcohol attributable risk or harm, then 6 standard drinks or less would probably be a reasonable goal. However, if they do have a risk in terms of family history of an alcohol attributable condition, I think that's where people might be encouraged to go down even lower and consider the low risk zone at 2 standard drinks per week. And definitely, if they already have an alcohol attributable harm, such as, or one that could be exacerbated by alcohol, such as liver disease, such as breast or colon cancer, and so on, those are folks that I would say, alcohol is not good for you. We're helping you to improve your health. You have this health challenge already. One of the things that you can do to improve your chances of success in maintaining as high a level of health as possible is not to drink. And provide them with tips in terms of how to cut back, how to taper, and encourage non-alcohol beverages. Again, it's not an attack on socializing. And I think this is where we sometimes get that overt emotional response. Alcohol plays such an important role in that transition from work to relaxation from the end of a work week to the weekend, celebratory occasions, and so on. So we just need to be thinking about, is this about the company or is it about the chemical? What is it as a society that we want or need, so that our social interaction doesn't have a negative impact on our health and well-being?
Thank you for that. Now, Hamida, something that had come up a lot in some of the questions beforehand and a little bit here is messaging in terms of maybe stopping the next generation from starting, messaging for youth, messaging for students when they're going off to university. We had a question in the comment box about the emotional traumatic experience for especially females when they're at university. You know, some of the discussions in the presentation talked about how males tend to become more aggressive and that sort of thing with alcohol. Not that that is an excuse, but what kind of messaging can we have for our younger people to maybe help them realize and fight some of those social conditioning that alcohol is accepted?
Yeah, thanks, Heather. And I do see the related question in the Q&A box. I think, you know, of course, we've all heard these kinds of horror stories, and it's very, very, very difficult. How do we have those conversations with our children? As a mother myself, I know that I'm going to be struggling with this very question one day. And I think, you know, just there are many resources available online. Halton Parents also has resources available in terms of how to have conversations with your child about various substances, so not just alcohol. And so promoting those resources to parents so that they can have those conversations. We work closely with our school boards to make sure that they have the resources needed to create healthier environments, which includes, you know, messaging related to substance use and not using substances, especially at that age. And certainly as we go down this path of knowledge mobilization, as Peter spoke about earlier, we're going to have to do a lot of education to lots of different community stakeholders, including universities and colleges, and making sure that every organization thinks about, at the very least, they think about having an alcohol-related policy in place. So this is work that we're committing to at Halton Region Public Health for the next 4 years, is that we are planning to put together a regional alcohol policy that we're going to do with the help of our local municipalities, with them on board. And we're going to work with school boards and various other organizations, whoever wants to work with us, including workplaces, to come up with those kinds of policies that help lower alcohol consumption in those settings. And you know, exactly what Peter was saying, it's more about the company than the chemical. So it's about those social interactions. How do we have a policy in place that promotes the socialization without the harm? And so I think we're going to be on this journey. And if any of you have any tips or ideas, we welcome them. But we are going to be on a journey to try and create those healthier environments.
Well, that's great to hear too. And as I'm a mother of 2 boys that are in this age group, and you know, all they see in the media is, oh, like my one son was saying, he's so excited to go to high school because that means he's going to go to all these parties where there's drinking and this. And I'm like, no, I'm in public health. That's not what you're going to do. So learning how to kind of reframe that the whole concept around drinking. Something in terms of that reframing is also, and Peter talked about it a little bit in terms of kind of that messaging that we've heard in the past about alcohol, red wine being good for your heart, or some of the charts that were in Dr. Butt's presentation in terms of the, you know, showing that there is some protective effect of alcohol on pancreatitis or diabetes. How do we kind of talk to our patients in terms of you know, what that messaging was, that alcohol was actually good for you, versus now that we're, you know, less is better?
Well, certainly with regards to that, it's important that people understand that the evidence has evolved, and what we have now is much more accurate. There are gaps, however, and you picked up on in terms of pancreatitis amongst women, and this is not one that makes a whole lot of sense. I think it's simply because the data came from surveys, and we just don't have it at the level that it should. It doesn't extend to the pancreatitis doesn't extend to males. Similarly, in terms of diabetes, it's not quite the same between males and females. So the mechanism doesn't make a whole lot of sense for a protective effect. But that's where the evidence is. We're transparent in the reporting. And I think that really it's a case of, again, thinking about this from a whole health perspective. And if people are thinking that drinking is going to help their diabetes, they need to rethink that with regards to the impact of their heart and the cardiovascular system, because of course, those are the complications that they'll encounter. So, there are other ways of unpacking some of this. I think practically speaking, and with regards to the question with regards to alcohol strategies and approaches, is an approach that's going to turn away from acute intoxication to avoiding that. And this is true for adolescents and youth as well, because traditionally it's peer driven and people learn how to drink by their negative consequences. So they drink, they get intoxicated, something stupid happens. Unfortunately, something tragic can happen, and then they adjust their intake accordingly. We need to be much more proactive, and avoiding more than 2 standard drinks in a sitting is wise. That's kind of a harm reduction approach to youth. You could argue that maybe it should be even less than 2, but you're dealing with a youth culture that thinks alcohol is normalized and thinks that binge drinking is normalized. Whereas in fact, when you look more broadly, that's not the case. So part of addressing it on university campuses and at colleges and with youth is emphasizing that there's a significant number of youth that do not drink or drink much more moderately. And the point of drinking isn't to get drunk. So, but this again is where the knowledge mobilization needs to be very nuanced. Similarly, we need to ensure that on college campuses and other places, people who choose not to drink aren't at a disadvantage. Concerts and so on are often promoted by the alcohol industry. And so they have beer gardens that get you closer to the stage. What about the people that don't drink? They're relegated to the nosebleed seats. And there's a problem here in terms of making it equitable with regards to access to these social activities for people who choose not to drink or just don't want to be around people that are drunk.
Excellent. Thank you very much for that. It'll definitely be a journey that will all be going on across the country as well. And it'll be interesting to see over the next 5-10 years how everyone's views towards alcohol consumption changes. I'd like to thank you very much, Dr. Butt, for taking time out of your really busy schedule to come join us today, as well as Dr. McGanney. If anyone has questions on this topic, feel free to email me at doctors@halton.ca. And I will be sending out the slide deck as well as the recording for the presentation, and also some resources to all the attendees, as well as those people that couldn't make it but had registered. So once again, thank you very much for everything you do. Thank you for your interest in tonight's topic, and we will see you shortly. Bye-bye.